will be recording this now. All right. Hi, everybody. My name's Mercedes Bern-Klug. I'm with the University of Iowa, and here today with the National Nursing Home Social Work Network. And we have a representative from the Center for Practical Bioethics, Ryan, with us today, who's going to talk about ethical issues. But Ryan, I wanted just to give you a little bit of an introduction to the Nursing Home Network so you have a sense of who you're speaking with and how we plan on using this information. And then I'll ask Ryan to tell us a little bit about the Center for Practical Bioethics, because most of you don't know about the center. And then Ryan, if you'll say a little bit about yourself, and then we'll go from there. So I'm going to start out. The National Nursing Home Social Work Network is a group of mostly social work professors and advocates and some organizational group members who gather quarterly to talk about issues related to nursing home social work. And so most of us are engaged in advocacy or research related to nursing home social work, and most of us have been doing it for, you can count it in decades. This group also helps coordinate a listserv. So the listserv is different from the network. The network is, think of it mostly as scholars and advocates. The listserv is 500 practicing nursing home social workers. And the listserv has been going on for, I think, 12 years. And so it's a way for the social workers to communicate with each other and share information quickly. And so what the network does is often we get information and then we share it through the listserv, or we get ideas for what needs are through the listserv and then try to pull together resources. And so what the people on this call are today, they're all members of the network or all social work nursing home advocates. And we will take the information that we learned with you today, Ryan, and then we'll share it through the listserv, but also through the other networks that we're part of. So the people who are on this call today are joiners. You call them joiners, or they've got fingers in different pots. They belong to different organizations and groups, and they're good at information dissemination. And they also have practical experience with older adults. Everybody here is trained in gerontology. So Ryan, would you like to talk a little bit about the Center for Practical Bioethics and then give us a little bit of a background of yourself, please?
Okay. So the Center for Practical Bioethics is a nonprofit organization in the Kansas City area, and we support all of our member hospitals who participate with us through ethics education, advanced care planning, training, and building up skills. That's my work. I am the director of membership and ethics education. My work is to sit on ethics committees, participate in patient ethics consultations, and help build skills and competencies in clinical ethics services within the hospitals themselves. We can't expect everyone to only be able to rely on the ethicist. Everyone needs to be able to have these skills. So I teach these skills so that everyone can have a good understanding of them and then incorporate them into their everyday work. Before I was a part of, one second.
We're having some little sounding issues. If you
having phone issues.
Good, we can hear you.
Okay. Before I was in Kansas City, I just started last June. I was in the Seattle area with Multicare Health System, where I was the department chair of bioethics and the head of the bioethics department. My work was building a bioethics department from essentially the ground up. I was overseeing all clinical ethics consultation services, policy development, chairing 5 ethics committees for 7-8 hospital health systems. And before that, I did my education and training at University of Pittsburgh Medical Center, and my degrees are at the University of Pittsburgh.
We are so fortunate to have you with us today, and I want to thank you so much for doing that. I see we've got some messages in the chat box. Joan, would you watch the chat box for me during this meeting and alert me if there's anything that I need to do to interrupt the meeting? Joan, would you watch the chat box? All right, so Ryan, you've got extensive experience with clinical ethics, which I love. And it sounds like a lot with the hospital. I'm going to spend just a few minutes talking about the nursing home context. We're
Okay.
mostly concerned with nursing home social workers. Nursing homes are not required to hire a social worker. Only if they have more than 120 beds does the federal government require them to hire a social worker. So they don't have to have a social worker, although most nursing homes do hire somebody in social work or social services. The federal government does not require a degree in social work to be a social worker in a nursing home. Every other healthcare setting that gets Medicare or Medicaid funding, you have to be degreed and licensed in social work, but not in nursing homes, which is a whole other separate issue. I just did a survey last year of nursing home social work directors, and half of them in the country have social work degrees, and half of them don't. So those with social work education, as part of their education, they are introduced to a biomedical ethics framework based on the 4 principles of biomedical ethics. They're also typically the only social worker in the building. And so they're isolated. They've been trained in a biopsychosocial spiritual framework, and then they're put in a medical setting and a nursing setting where that is very task driven, and they are more process driven. So they're part of the reason we exist as a network is to help people feel less isolated, to help people feel more connected. And now, especially in the context of this pandemic, we really see our nursing home social workers feeling very isolated. And we want to do all we can to help them feel connected. In the nursing home setting, it's the social worker who's responsible for residents' rights. So their job is in part training residents, staff, families about resident rights. And so that's a really important background, because in this pandemic, that's going to be one of the issues that they keep bumping up against. Hey, wait a minute, I'm supposed to be protecting resident rights, but now I'm setting up policies and doing things that are a little counter to resident rights because we're in a pandemic. The other issue is nursing home social workers are typically the person involved with advanced care planning and advanced directives. And so they're going to be having to now contact families who are no longer allowed to visit by phone to talk about advanced care planning. So it's difficult enough to talk about it in person if people are willing to talk about it, but then to do it by phone, and that adds a whole other layer. And then it's the social worker who also handles when families are upset about something, about anything. The social worker is one of the on-site advocates. So this person is being pulled in many directions. And if they have the social work education, they've had some preparation and some training and some socializing in crisis management and decision-making under pressure and things like that. But remember, half of our nursing home social work directors are not social workers. 20% have a high school degree, and they're in charge of nursing home social services. So that's the context. They also have, of the person in the nursing home setting, they probably have more psychosocial education and experience than anybody else on site. Because in most nursing homes, there is no medical director on site. The psychologist is not on site. And the registered nurses are doing the MDS. So our social worker is our psychosocial pillar in the nursing home setting that we want to build from. So about today, we're hoping that you can give us some information that we can share with nursing home social workers about how to approach the ethical issues that are arising in the context of this pandemic. And so if you wanted to just talk a little bit about the ethical principles in general, and then how they're different or could be different in a pandemic, that would be great.
Sure. So some more background about me. My education is in philosophy. That's my approach to a lot of these topics. I studied meta-ethics, this type of stuff. But then my work experience is very practical, very much in the clinical setting. I also was the program overseer of our advanced care planning called Respecting Choices, Honoring Choices Pacific Northwest in Seattle. So I've built bioethics aspects within advanced care planning, had advanced care planning conversations, worked with social workers on how to teach these skills and train the trainer model, so very familiar with that. And when I was at UPMC, I also worked in complaints and grievances, so crisis management, connecting with patients, helping solve these issues, so trying to bring people down. I've always felt that the number one thing that a lot of patients are looking for whenever they're having a crisis is they just want to be heard. They want someone who's willing to sit down and say, I hear you, I understand your issue, and we're going to do everything that we can to rectify it. And just that level of humility and acknowledgement to the patient usually brings down tempers and starts everyone starting to work together, because we're all trying to achieve the same things. It's just we're coming from different perspectives, and then sometimes we don't necessarily understand where the other one's coming from. That's where the conflicts come from. Going into the medical ethics, everyone knows the 4 principles. They're beneficence, non-maleficence, autonomy, and justice. That is, autonomy is a patient's right to self-determination. We can't force patients to have surgeries that they don't want. If a patient has capacity, is knowledgeable, is aware, able to give informed consent, they're able to accept or refuse any medical treatments. Beneficence is our obligation to do good. Non-maleficence is our obligation to do no harm. And justice is proper allocation of resources, treating like patients as like. Not every patient gets exactly the same treatments. That would be like if a woman came complaining of issues around her breast, would be different than a man complaining of issues around his breast. Like, you treat different patients differently, but you treat like patients like. And understanding those similar variables is where the challenges come from there. The perfect patient interaction is when all 4 of those principles are upheld. So an example of that would be a patient comes to the hospital, they go see their physician, they're complaining of painful urination. The physician believes that's a UTI, prescribes the patient an antibiotic. Patient goes to the pharmacy, fills it with their insurance, pays a copay, costs them $1. They take the antibiotic for 3 weeks, and they're cured. All 4 of those principles are upheld. The patient chose and wanted to participate. The physician is doing good. The physician is not causing harm, and the patient is able to access the resources that are necessary. Ethical issues arise when 1 or 2 of those conflicts are in conflict with one of those principles are in conflict with each other. So what if the patient doesn't believe in antibiotics and refuses to take the medication? We would have a conflict between autonomy and beneficence. So are we doing good for this patient, or should the patient be allowed to make this determination themselves? What if it's like chemotherapy and comes up with some really extreme side effects? That would be beneficence versus non-maleficence. Are we doing good for this patient, or are we doing harm to this patient? And then what if the medication is extremely expensive, insurance while paying for it, it costs $20,000 to fill that prescription, and the patient can't afford that? Now it's autonomy and beneficence versus justice. And a lot of the work within clinical ethics is understanding which of these 2 principles are in conflict with each other, and that helps us to understand how to move forward with it to the next step. So some of the work from Johnson out in the University of Washington, he wrote a book called Clinical Ethics, and he brings it down to even more clinical language. So he uses the terms, instead of the 4 principles, he uses, it's called the 4-box method, and that's patient preference, medical indications, quality of life, and then contextual features. So this is, you fill in these questions and those aspects, and then where you're seeing the conflicts come about within those boxes, you can start working with it more. What we're seeing here, the webinar we were hosted yesterday with Carla Kearns talked about how we use a deontological approach in most clinical ethics situations, and now when we have a pandemic and these extreme situations, we're moving into a more consequentialist, utilitarianistic perspective.
We can't hear you. All of a sudden we lost your sound. And so Ryan, that brings up an issue. Has the field decided it's time to switch to a more utilitarian? Is that consensus, or is that a suggestion, or is that an option?
Can you hear me?
Yes.
It's more of, this is kind of, the literature supports it, but there is still a lot of difficulty with it. For the most part, I personally, this would be my own stance, I reject utilitarianism, particularly in the clinical setting. An extreme example of utilitarianism, which is the most amount of good for the most amount of people. So the consequences determine the righteousness of an act, and you measure the calculus of how many good people are you harming, how many bad things are you doing, and then you balance that across. The example of this is the trolley problem. It's, say you have a trolley that's out of control and 10 people are on it, it's going to crash and all 10 people are going to die. You are standing down the tracks and you could push a person onto the tracks that will kill that person, but it will slow down the trolley and all 10 people would live. What do? Do you push the person onto the tracks? If you believe in deontological arguments, you say murder is wrong, you have a duty to that person, and you don't sacrifice people for the greater good. If you believe in consequentialism and utilitarianism, it's 10 people live, one person dies. Yeah, we don't like that one person died, but this is the situation we're in, and we have to accept that 10 is more than one. You're doing 10 good, one bad. It balances out to a +9. That's the action you should do. So going with like quarantine ethics, during the Ebola crisis, we saw this where patients, physicians and patients were coming from West Africa, they would immediately be quarantined, isolated, and they didn't have a say in the matter. And this was a limited time, 3 or so weeks, and then they were allowed to enter society. What we were doing is we are stripping away the rights of that person to make their own medical decisions, to live their own freedoms, to have their own lives for the benefit of others down the road. And we're starting to see that during these situations, we don't particularly like these decisions, but for the most part, we have to think for the greater good. And this is where clinical ethics and bioethics and public health ethics become drastically different, where bioethics is very focused in on, a lot of times, clinical ethics and bioethics, the individual patient. What is right for this individual patient, and how do we promote the health of this person? Where public health ethics is, exactly as the name implies, the larger group. So as you start expanding outward and involving more of a patient set, the more utilitarianism makes more sense. But whenever you start individualizing it, then it starts to become more difficult, where if you look at the trolley problem as a situation and just as a statistic, then yeah, 10 people lived, one person died, that makes sense. But then whenever you individualize it down to you killed a person, that always seems wrong. And that's sort of the work of philosopher Bernard Williams, where we don't like these ethical systems that require us to do things that we know that we shouldn't be doing. You should never want to take away a patient's rights. You should never want to do these things. But these situations dictate that that may be the best option available, not necessarily a good option, but the better of the alternatives.
So the public health ethics, would you say, is more of a utilitarian approach, or are they still separate approaches?
I would say it's more of a utilitarian approach. There is some people who argue a more utilitarian approach in the clinical setting and the individual, but for public health, it definitely moves to a more utilitarian because you're bringing in a lot of different perspectives. And this kind of brings into the ideas of like the social contract. The social contract is an idea of the more you live, it's an agreement that we all basically sign by our participation in society, but there's no like official agreement. If you want to, like, I don't know how to hunt. I don't know how to go gather food and provide food for my family. I benefit from living in the society that I could go to the grocery store and get that resource. By living with other people, though, I have to sacrifice some of my own rights. If I can go access that grocery store, I know I shouldn't be hurting other people, or I shouldn't be yelling fire in the grocery store. The benefits of living in the society means that you have to, like, you individually choose to sacrifice some of your rights. If you want to go live in Montana on a huge ranch with 1,000 acres and nobody around, you can essentially live however you want to live and do whatever you want to do, but you're not going to get the benefits that come with having a close society. You're not going to be able to have the grocery store aspect, the electricity aspect, like all these utilities that we rely on and we like our lives. And it's a balance of that. And it's the more you want to live with society, the more we essentially accept the limitations of our freedom. And I think that is where the drive with public health ethics comes in right now, is we want to live in a society, we want to live around all these people and get the benefits of that society, but then we understand that if one of us gets sick, the damage that we can do to everybody else. It's positive rights and negative rights. While I have a right to my own health care, my own determinations of my own health care, you also have a right to not get sick from me. And your right is to some extent almost as equal as my right to do that. And since we're agreeing to live in a society together, I have to acknowledge that I need to sacrifice my own right so that all the other people can uphold their rights as well.
All right, so here's a real life issue that one of the social workers brought up. Is it ethical to change everybody in the nursing home to do not attempt resuscitation, especially people who already have the COVID? Can the nursing home say, you have COVID, we're not going to attempt resuscitation, even if you're not a DNR before?
And can I chime in on that? Because can I chime in there? Because I have a similar question, which is, and I put that in the chat, because this is really about healthcare rationing to some degree as well. And we're facing that, you know, it's like slamming us in the face right now with the, you know, lack of ventilators and other equipment. So, you know, how do we work with the people in nursing homes to help them to understand criteria upon which they should make these they shouldn't make these blanket decisions, but how do we help them to set up criteria for decision making, like triaging and things like that?
Our organization is right now working with a lot of others and creating like policy guidelines. Particularly, we're using the Missouri. I can send out this documentation to Mercedes and she can send it on, but it's pandemic ethics triage policies, where I strongly reject a unilateral do not resuscitate for patients with this condition. I would be more inclined to go that a patient with COVID who would not benefit from resuscitation anyway could then have a more paternalistic mentality of we should move them to a do not resuscitate against their wishes. But that would be very extreme and also individualized to that patient based off their prognosis and expectations. A lot of it we're doing is SOMA scores of, do we expect this patient to benefit from resuscitation? If the answer remains yes, then personally, I don't care what their diagnosis is. If they can benefit from it, then they should benefit from it. But if they have COVID and they have congestive heart failure with no expectation of meaningful recovery, long-term neurologically compromised state, and we don't expect CPR or resuscitation to have the benefit that that patient's looking for anyway, then I would be more, see it as more ethically permissible to move to a do not resuscitate for that patient. But where Italy and a lot of others are putting in recommendations of age determinations, I don't particularly support that as well, because my time in the clinical setting, I've seen some 80-year-olds who are far healthier than 50-year-olds. So, and going 65 plus, you benefit from resuscitation. That's, I think, too broad of a generalization. There's a strong dynamic within humans to create everything into binary systems. Everything is a yes or no. Everything is a do or a don't, a good and evil, right and wrong. And the more we really study the world around us, the more we realize that's not how the world is. Everything is shades of gray. Everything is on spectrums. Everything is on continuums. And we need to understand that. But when we take these incredibly complex situations, like who gets a ventilator, who would benefit from these treatments, should we do these treatments on these patients in this state and risk larger scale problems, we start to go into boiling it down to a binary question of, if they're over 65, do they get a ventilator, yes or no? And that helps us to understand that. But what it is within like formal logic, it's called a logical fallacy. It means it's not like a wrong argument. It means it's not even an argument in itself. And you can't even move forward with the arguing because it's just essentially voided itself because it doesn't make any logical sense. And saying these binary of like, immediately, do we do unilateral resuscitation or do not resuscitation on are they COVID-19 positive? Yes or no? If it's yes, then we do to a do not resuscitate. That takes away all the complexities of the clinical situation that this patient's actually experiencing. And we're reacting with fear and uncertainty because there is a lot of, we don't really know what's going on right now. We don't know all the finer details of this patient. But can you think of any other, I can't think of any other situation where if a patient presents to the hospital or a nursing facility with this condition, that we immediately move to a do not resuscitate. I've seen patients who are congestive heart failure, and we know that they would not benefit from resuscitation. We really know that. But the patient says, I want resuscitation. And we say, okay, like, you have that right. We will explain to you why we think it's a bad idea. And we will explain to you why we have moral distress about it. And we really don't want to do this. But if the patient says, I appreciate that, I understand that, and I fully support it, but I still want resuscitation, then we say you still have that right. That would be going to the ethical principles, autonomy versus beneficence and non-maleficence. Are we actually doing good for this patient, or are we doing harm for this patient? And does the patient get a right to make that determination? And my way of thinking about it is we don't want to do harm to a patient, but harm is also individualized to the patient. Patients determine what is harm and what's not harm. What I might see as a harm to myself could be very different than what you would see as a harm to yourself. And the only way we can determine that is by having that conversation with the patient. This is where the value of advanced care planning comes in, and having these detailed conversations about what is important to you, what is a harm, what is not a harm. Would being on a ventilator for a long-term future, would that be a harm to you? Some patients would say no, some patients would say yes, and we don't know what that is to uphold that patient's right without having that conversation.
All right.
So we need to allow these patients to be able to express themselves, but not just create these unilateral determinations based off statistical anomalies rather than focusing on the individual patient.
So if the individual patient has COVID and it looks like they require mouth-to-mouth resuscitation, is a staff member obligated to put their mouth on the COVID person's mouth and give them resuscitation?
I would say no, because we would never require a health professional to risk their life to help another patient. It could be a benefit and the patient could benefit from it and it would be good, but it wouldn't necessarily be a requirement. This comes into one of the issues of the principle of all the other ethical principles besides beneficence are negative aspects. Patients have a right to determination. You know what that is. Don't do things that the patient doesn't want. Do not do harm to a patient. Do not refuse resources to a patient. Beneficence is more challenging because it's saying you have to do something. It's a positive aspect. So you have to do good, but it never says how much good are you supposed to do. Are you supposed to see one patient and have a great conversation with that patient and really put in the time, but you only saw one patient that day? Are you doing good? Or are you not doing more good that you should be doing by seeing 20 patients that day or 50 patients that day? Should you be volunteering more? Like, it doesn't really set up those expectations in realistic ways, and it doesn't fully explain it. So there's like kind of the arguments of like baseline beneficence of like, this is the minimum amount of good that we expect you to do. And then there's superfluous beyond that of like, you're doing more. So I would say in that situation, caring for the patient, treating the patient, that would be doing good for that patient. But if they require mouth-to-mouth resuscitation and you would have to risk your own life to do that, then that would be an obligation that we cannot expect you to meet. That would be the same as if you have a patient that's requiring a kidney transplant and you have 2 healthy kidneys, are you obligated to donate your kidney to save that patient? And we don't say that you have that obligation. So I would use that same analogy to this situation of it would be wonderful if you did, but we cannot expect you to do that.
So on that front, can I add to that question? So where do we consider then drawing the line in terms of risk for the staff? So the not having personal protective equipment is not only relevant to, say, having to give CPR, which is obviously incredibly risky, right, if somebody clearly has COVID-19. But what about just going into their rooms without that equipment, which we're hearing that, you know, hospitals are even having trouble getting that equipment, and nursing homes as well. So, what direction do we give to a nursing home where they're saying, can we make our aides go in and give somebody a bed bath if they have symptoms or are diagnosed?
I think that same situation applies to this. If you have an obligation to your patients, we've all taken oaths, we've all agreed that we are caring people and we want to care for our patients. But while we have obligations to our patients, our structures have obligations to ourselves, have obligations to us as well. So, and one of those obligations is to provide sufficient protective equipment so that we can safely do our work. So if you are able to receive the proper protocols and precautions and safety equipment, then I would say, yes, you have an obligation to treat these patients. But if you are not receiving what is expected for you to be able to do your job safely, then I'd say you do not still have that obligation. So back to the argument of, yes, it'd be great if you did, but we can't expect you to do that.
And what we're learning is that in most nursing homes, there isn't enough protective equipment to give it to the social workers and the social work assistants. And the social workers are still being asked to go into the rooms and do video chats with the residents and their families and things like that. But there's not enough equipment. The masks go to the nurses, and the social workers agree that the nurses need those masks and the gowns, but there are not enough masks for the social workers.
It's the same as if they said that they don't have the funds to pay for the social workers anymore, but they still want you to show up every day and work for free for the rest of your career. Would that be a realistic expectation on you? I would say no. There's an obligation to you as much as you have an obligation to others. So while you have an obligation, they have to require that protective equipment. And what we're seeing in these situations of crises is our normal standards get more challenging to uphold. So certain things will have to be sacrificed. Certain aspects of care will have to be limited based off our inability to deliver that care. I see personal protective equipment to social workers as essential as a scalpel to a surgeon. This is something that is necessary for you to be able to safely do your work. And if you are not able to safely do your work, then we can't expect you to continue to do your work.
Wow.
Not to mention that also, I mean, raises issues for, now we're flipping to sort of the greater good, but if, say, a social worker is going into somebody's room without protection, they are more likely to contract the illness, and then they're going home. They're leaving the facility, and other staff are too. So anybody who doesn't have that protective equipment is at greater risk to not only contract the disease or I mean, I don't know how long these germs live on a person's body, but right, they could be carrying it because they didn't take off a layer of, gown and glove and all that other stuff. So there's a public health risk as well.
We're using public health ethics to require social workers and nurses and physicians to take sacrifices, think about the greater good. But if we're continuing that argument, if you take public transportation home and you haven't had protective equipment and you become a carrier, how much harm are you now spreading? How much are you taking home to your families? Are you doing more to spread it than the good that you're actually doing within the system that we're doing? So if we're going to say the greater good is the most important, we need to all make sacrifices for that greater good, we have to continue that argument to support everyone. I think that we are all really focused on our patients and we all really want to do what's best for them. But when we become patients as well, we need to focus on us as well. We need to heal the healers. We need to be able to do our work properly before we can actually be expected to do our work.
Are there other questions that people want to raise, ethical questions to have Ryan respond to? You can put them in the chat box, or you can put them, or you can just start speaking. It would be great. I can't see everybody.
And I have a question for you. In terms of the community response, we know that it's lax in some areas. We know that people are being asked to go into workplace situations without protected equipment, being asked to reuse. We're being told by by the federal government that aid will be coming, but it's going to be coming later on. From an ethical standpoint and looking at this whole backdrop and picture, how does that fact interact with the greater good and expectations for professional performance?
I do not see any ethical restrictions in asking people to put themselves at risk to provide for others. But I do see issues ethically with them being told to. We cannot compel you, we cannot force you, but we can ask. We could always say, it would be wonderful if you did. And if you choose to, that's upholding your right to autonomy, of your right to make a self-determinated decision. But now coming from like the social structures that we have, how much asking and how much freedom do you actually have to make this call? That becomes a larger issue. But I do see the responsibility is public health is essentially saying we are not all individuals. We are a larger collective, and we need to look out for the health of that larger collective as well. Most importantly, like the organism is more important than the individual cells. And if you're one of those individual cells, yeah, you don't like the idea of being sacrificed, but you have to think about the greater good. But that needs to be applied uniformly. So if we're saying that this is how we need to treat our patients, what about the middle people? They need to be treated properly as well.
So along with that, we have professional codes of ethics, and we have standards for work practice in various states, and in various states there's different versions of what's expected of individuals. And then you have the whole area of virtue ethics. So putting that all together in terms of the greater good for the greatest number, and not asking people to, or forcing people to do things that they don't want to do, how do those professional standards and virtue ethics come into play?
So virtue ethics is actually the ethical system that I adhere to the most. It's essentially saying that virtues are, we'll go like an Aristotelian argument, which is the middle between two extremes. So what is a brave person? A brave person is the virtue between two vices. If you're a soldier and you want to be a brave soldier, the soldier who rushes headlong into 10,000 enemies by themselves, that's a fool. But the person who turns around and runs, that's a coward. A brave soldier will be the one who stays in the middle and fights bravely. So you don't want to be a fool, you don't want to be a coward, you want to be brave. In terms of like eating the appropriate amount of food, or drinking the appropriate amount, or enjoying life the appropriate amount. You don't want to do it too much, but you don't want to do it not at all. You want that middle ground. And then it gets into a complicated of how do you become virtuous? You find these virtues and you demonstrate these virtues, and then you have to continuously demonstrate these virtues. And then how do you really find how to be a virtuous person? Is you find someone who is virtuous, and then you act in accordance to them. So in terms of these situations, I would say that from a virtue ethics model is we don't want you to not treat patients and not care for patients, but we also don't want you to sacrifice yourself completely for the benefit of those other patients. Being in the middle ground of caring for our patients, but caring for our patients in a safe and meaningful way is a virtue. And that is the expectation that we would have, is we want virtuous social workers, but virtuous social workers would not be foolish, or they wouldn't be cowards. We would wear protective equipment, but then we would still go in there. I mean, going into patients, I feel some level of risk when we go into patients and we gown up, and no matter what the disease is, we are always putting ourselves at some level of risk. But whenever we have the proper safety precautions, we feel accepting of that. Our codes of ethics are, we were willing to do that. We are willing to take that sacrifice when these expectations are being met. But whenever those expectations are not being met, we can't have that same obligation. So if you're saying you want to be a virtuous social worker and go do what you're expected to do, and you agree to with these safety precautions, and then we take away those safety precautions, can we still say that you're not being virtuous or not agreeing to that code of ethics when the expectations for being met are not actually being met? sorry, that was a little circular, and virtue ethics sometimes gets a little circular of like justifying itself with itself.
I think that was an excellent answer, and my read on what's happening is that people are really like responding from that virtuous perspective, because they have a professional obligation to do the job that they're required to do, and they're being right now put at great risk. So there's a lot of balancing that needs to go on in terms of expectations and in terms of how we're going to care for our individuals. And there really are no right or wrong answers here, you know?
Right.
There's a
And
lot
that's what
of things
I was
coming
saying
into
with
play.
like the binary aspect. There is ethics is not necessarily a put in situation in slot A and slot B, the right solution comes out. It's more of like how we think about things, how we use these systems. And that's where like deontological arguments, utilitarianistic arguments, virtue ethics, care ethics, principalism, the world is messy and we're never really going to be able to understand it. That's meta ethics. Is there even an ethical system that is right? But the systems we have are more, we're never really going to be able to understand that. This is the best we can do within the system that we have. But we use different systems in different situations for when they're called for.
I think this has been so helpful, just extremely wonderful, because it also helps remind us that we're making decisions today, right now, but the consequences can be days, weeks, and months later. So if all our social workers rush in to help people without the protective equipment, they're going to get sick, and then they're not going to be able to serve anybody. So
right.
I think this is a very useful conversation. I want to take it in a different direction, and that's working with nursing home residents with dementia. So to the group of nursing home social workers, that's almost a completely different situation, because we can't reason with people with dementia, and touch is so important. And so if people don't have the protective equipment and can't go in and safely give them a massage or sit next to them or reassuringly hold their hand, there's a lot of moral distress that the activities staff, the nursing staff, and the social work staff are feeling by leaving people with dementia alone, and they often like to wander. And so if they're wandering around, they're putting themselves at risk unknowingly if they're going into somebody's room with COVID and all that. Anything that you can enlighten us about working with people with dementia during a pandemic?
Nothing that I can really give a solution, because that's a very challenging situation. The only recommendation I could have is, if we're triaging protective equipment, it should maybe go to the social worker who's going to see the dementia patient first, so that they can be able to provide that care, rather than another patient who doesn't have dementia who could be more properly reasoned with.
Okay, that's helpful to think through also. Other questions or issues from anybody else on the phone? From your experience, Ryan, what else do you see that might be coming down the pike that we could start thinking about or start preparing people for?
I think we're in the start of things right now, and we're dealing with these current ethical issues, but the longer ramifications of this event is going to cause shifts within how we deliver care, and it's going to create new ethical issues. Having the example I heard was having everyone stay at home and social distancing is very appropriate, but now we're going to see rises in, to some extent, domestic violence, child abuse, personal health issues are going to go up. What are the long-term ramifications for this? And then how do we deal with that? And this is the problem we're seeing, is this is a situation that we weren't necessarily prepared for. And now that we're in it, we're showing how unprepared we are, and how our ability to deliver care properly is not being fully upheld. We need to start thinking about what are even not like likely possibilities down the line, but what are some potential possibilities down the line. And we need to start mentally preparing ourselves for those, so that whenever we do experience them or find ourselves in them, we're not in this situation again. where we're going, oh, we didn't see this coming and now we're in it. What do? We need to think like, this is a realistic end that might come of this. How do we solve that? Or how do we work with that when we get to that? And what do we need to be doing right now so that we can essentially remove that possibility? Or when we're in that possibility, we could possibly be doing what we can properly.
Paige, I
So
think you're unmuted now if you want to go ahead and speak.
Thanks, Merce. I was just curious between ethical and moral dilemmas and how I was thinking about your examples, Ryan, of, you know, you have a staff member, whether it's a social work nurse, nurse's aide, and they want to go in and help the person, but they have no equipment. They're sitting there watching that person suffer. And I'm thinking through how traumatic that would be for the individual. And I'm also thinking long-term in terms of how we as healthcare providers are going to be judged within the community, our immediate communities, and the greater community and the nation, because as you might know, nursing homes certainly do not fare well, typically demonized and put down. So I'm just struggling with how to work with that. What do we help staff, how do we help convey to them and help settle around these horrific decisions?
During my work in Seattle area, I also worked on, we called it Code Lavender. It's a moral distress alleviation team. So one of the things, the difference between ethics and morals, morality is very individualized to the person. Ethics is the systems that we have. So we have codes of ethics and we have ethical systems, and these determine through that structure right and wrong within that system. Morals is to the person, and it changes every day. Your morals may be very different than they were 10 years ago. They may be very different than they're going to be in another 10 years. They may be different than they are next week. They're always changing. They come from life experience, and you don't necessarily have an ethical system individualized to yourself that you may be violating when you think something's wrong. It's just a gut instinct of, I know this isn't right, but I can't formulate it. Ethics is more, under this argument, in this structure, in this system, we have determined that to be wrong. So I've said many times, to be a good ethicist, or a lot of times to be a good ethical person, you often will have to sacrifice your own morality. It's been a lot of times working as a clinical ethicist, excuse me, where I would put in recommendations that were ethically sound or the right ethical decision that I personally very much disagreed with. And I didn't think that we should be doing this. I didn't think that this is the right thing. And I would not have agreed to that personally. But I needed to be able to acknowledge that, understand where I'm coming from, where my biases are, where my rationality is in myself, and realize I am not supposed to be putting in what I think is right. I should be putting in the chart what we have determined in a larger structured system, what is right and wrong, because we don't want to be influenced too much by our own personal morality. So while it will be very traumatic and very morally distressing for everyone, we're all going to experience that. And we need to understand that we're doing what we can, and we're doing what we can to the best of our abilities, but it's always going to feel bad. And I think I teach at Kansas City University Medical School, where I teach student physicians who are going to go off. And I say, has anyone here experienced the death? And they all say yes, or the third years will say yes. The first years say no, but they go, one question that one student had for me was, when does it stop hurting whenever I have a patient die on me? And I said, if you're lucky, never. Because it should never stop hurting. It should never feel okay to not be able to save someone or not be able to deliver the care to the highest of your ability. It's always going to hurt. It's always going to feel upsetting, and you're always going to be unhappy about it. But you can learn to accept it and understand that you did everything you could, but situations are going to be outside of your control. And as long as you do what you know is right professionally and ethically, then you can deal with it in a better way. But you're going to be working for the next 50 years of your life, and for every single death is always going to hit you. Every single situation like this in the pandemic is going to be challenging, because it's a sign that we're human. It's a sign that we still feel. And I believe that everyone who went into healthcare could have gone into any other field, and done really well for themselves. We chose to go into healthcare because there's something about providing for other people that we want to be doing. We want to be caring, and we are caring people. So that's why we are drawn to this field. So we want to do everything that we can. And whenever we're in situations like this, it's that nature within us of we want to be doing more than we don't accept the limitations of the structures that we have right now. And that's where we're finding right now, sometimes the structures halt us from being able to deliver the most amount of care that we possibly can. And that really hurts us because we want to be doing everything we can.
Ryan, may I ask you a question? And it's a naive question, but I feel like I need to ask it anyway.
Okay.
So morally, the whole staff is going to have their own moral compasses. Would it be of service to these nursing homes if the nursing home staff agreed to apply the same ethical framework? So that even though they individually will have different feelings, if as a nursing home, they agreed to apply virtue ethics or they agreed to apply this 4-box method, then they have a shared language and they try to do a shared culture. Do you think that that's reasonable? Do you think it could be helpful?
I strongly would support that. That's kind of the rationality of codes of ethics, where we have the nursing code of ethics, social work code of ethics, physician code of ethics. It's everyone's going to have their own moral compass. Everyone's going to have their own, I think this is right and I think this is wrong. But what can we all establish as our guiding principles as a group? And are you able to accept that? And there's a lot of physicians who agree to the AMA code of ethics, and they may not fully agree with every single aspect of it personally, but they say, I can do that. I can agree to deliver that care in that manner as determined by this. So we all have our own morality, and we all will be all over the place, but we create these organizational codes of ethics of this is what we agree on. Yes, and everyone says yes, and they go, okay, now we can go forward in putting these decisions in place, and we can at least respect each other that we're all coming from the same place. And that's what those attempts are trying to do.
And could you recommend an approach that we could share with nursing home social workers, and they could see if the rest of the director of nursing, if the CNAs, if the administrator, if everybody would be willing to use that structure, that language to think through these things? Is there an approach that we could share with them?
I could do more research on that, but right now I strongly recommend principlism, where the 4 principles of bioethics, autonomy, beneficence, non-maleficence, and justice, and just say, this is what we're trying to uphold at all times. This is our focus. This is what we're trying to deliver. And certain situations are going to come up where we're not able to uphold one of those principles to the fullest level, but that's when we will figure out a way to work with it and navigate around that when we're able to identify what the principles are in conflict with each other. But this should be our goal. And I think that's important because justice is public health. Public health ethics goes into the principle of justice, but that's only one of the 4 aspects. We also, just because we're in a crisis, that doesn't mean everyone loses all of their rights. Patients still have autonomy. We still have our obligations to do good and not do harm. And that is not just directed towards the patients, that's directed to us. We are expected to not be doing harm to ourselves. We are expected to be doing good to ourselves as well. And the public health aspect of the justice is just one component of this larger framework that we need to consider.
Would you say that 4-box method is a good method that takes the principlism and puts it into practical use?
Yes, the 4-box method was created in terms of the principles are very philosophical, very theoretical. The 4-box method is taking those principles and teaching it and applying it directly to the clinical setting. Is you don't have a PhD in philosophy and worked in ethics for the last 50 years, but you know these issues, you know patients, you know how to deliver care. Here's some language that you understand that's the same thing that we're talking about. It's just creating shared terms. So while a lot of healthcare providers don't necessarily know beneficence, they know what are the medical indications, or non-maleficence, they know what's quality of life, or what's the patient's preference. Like we know these terms so we can have these shared conversations.
And it was Phillips who was the author. What was the author's full name, please?
Johnson, Al Johnson, Johnson. S-E-N. And if you Google Johnson 4-box method, it'll come up.
All right, very good. This has been so helpful. And if everyone's okay, I'd like to share it with people in social services, social workers and the non-social workers who are doing this very, very difficult job. I want to thank everybody in social services that's doing this. And those of you who don't have a degree in social work, you're an asset, and we need to support you and give you resources as much as we can to help you as well. And we want to keep this conversation going. Ryan, anything else you'd like to say, or any other questions that people have?
It's just, these are challenging times, and the situations are going to be challenging as well, and our solutions are going to be challenging. And we need to understand what we share culturally and what we share personally, and do everything we can to uphold those, and understand that we are all human and we're all valuable, and mistakes are going to be made. But if we're all striving towards the same goals, then we can all understand where we're coming from and appreciate the work each other are doing.
Well said.
This is Anita. I do have a question, but I know we're out of time, so I can always just bring it up at the networking next Friday if you want. I don't know how people.
Let's hear your question.
Well, and so I've been a social worker 35 years in a lot of different medical settings and social service settings, and I don't have a lot of long-term care experience, about 18 months. But when we were talking on the previous call about reviewing or actually doing advanced directives with residents, and I know those who come into long-term care are, you need to have it. But with this current situation, is there certain language? Because I'm not sure, even though all the different professionals involved may have their own code of ethics. I'm just curious, you were saying earlier, Ryan, about maybe common language that could be used, because we have residents that are dealing with different issues. They may be coping psychologically with this situation, even if they're there for short-term rehab versus long-term care. People have said to me, I know I'm going to die at some point, but I don't want to go out this way. What kind of language or suggestions are there for the frontline social workers or staff? And what if an advanced directive is completed with a social worker and a resident, and then the physician comes in with a different perspective? I mean, I'm sort of curious about, I think that happens even without a pandemic. So I don't know if that's something that you could comment on.
I could comment for the rest of my life on that, because my specific philosophical research is the philosophy of language as applied to advanced directives and advanced care planning.
Oh, wow.
So I've spent essentially my entire career focusing on the words we use in the clinical setting and then documenting them and the limitations. So I use like Bertrand Russell, Ludwig Wittgenstein, Saul Kripke, like the limits of language as applied to conversations, and how what we're talking about is always lost within those ideas. Of what patients say is they have their own ideas in their mind, but they're restricting what they're thinking into words, saying those words, and then if you have a different understanding of those words, you don't necessarily get what that patient is saying. So we try to bring down the conversation and not use terms or use like ethical language, but we use concepts. So if we say like, what are your medical decisions? Ways that I would do advanced care planning is I used to ask patients, what's important to you? What does a good day look like? If you could be doing anything today, what would you want to be doing? And then say, okay, well, with your condition, we know you can't be doing that, but what's an unacceptable quality of life? Where I have a level of quality of life that I like, and if I were to, there's a very big difference between lowered quality of life and unacceptable quality of life. Mm-hmm. Where, yes, I don't particularly want to lose my leg, but if you told me my option is lose my leg or die, I'd say, yeah, I'm okay with losing my leg. Mm-hmm. So it's a lowered quality of life, but it's not an unacceptable quality of life. So, but that's not language that patients really understand. So it's more, what's important to you? What is the most important thing in your life that you could not live without? And I would guarantee you 90% of patients will say, interacting with my world, be that family, be that myself, be that my entertainments, my residents, like all the interaction of the world, that is very important to people. But if you just say, like, what is the most important thing of your life right now, that if you could not have it and be able to do it, that would just be a life not worth living, and hear what they say. I also learned palliative medicine techniques. And one of the ones that I was taught by my mentor was creating awkward silences and not telling patients things, but opening up conversations. So instead of, when you're in a scary situation, identify the emotion and then stop talking. And it's really uncomfortable for healthcare providers because we want to talk. We want to tell them, we want to reassure them and be there. So if a patient's scared, just say, I know this is really scary. And then just stop talking and see how they respond. And a lot of times patients will start sharing with you information that they didn't really realize that they were going to share with you. But if we treat everyone by the Missouri Hospital Association's advanced directive is written at a 14.4 grade level, patients don't understand what they're signing. It's written by lawyers for lawyers to be used in court. What patients understand is, what's scary, what's important. Tell me something. And if you give these patients the opportunity to speak, they will speak. Just creating the space, creating the environment, allowing them to feel comfortable of, I'm a person you can trust and you can share with me. Share. And I really want to hear what you have to say. And patients feel that, and they will start sharing with you. And it may not be the perfect advanced directive checkbox of, yes, I want resuscitation. No, I don't want antibiotics. Yes, I would want IV fluids. But you can really get a sense of what a patient truly would want from having these types of conversations.
And if the conversation is over the phone with the family, do you have any tips?
Can I
Yes, continue.
Can I just interject, just dovetailing into what you said? It sounds a lot like the Conversation Project. And I did a lot of work with the Conversation Project. And just for the people on this call, there is the Conversation Project Starter Kit that has a lot of the questions that he was talking about that are in that starter kit. So if you wanted to reference that, just Google the Conversation Project. You'll go to the website and you can access the starter kit there. I know that you did Respecting Choices, but I worked with the Conversation Project in some of the work that I did with nursing homes. And I found, particularly for minority populations, that Conversation Project starter kit really resonated with them. And I think
I worked with a palliative nurse in Seattle who was a huge advocate of the Conversation Project,
Yeah.
and she introduced me to it, and we used their material a lot as well. So I found it very valuable.
Yeah, it's doing exactly what you say. It's taking those words that we use and bringing them down to a level that people can understand.
Ryan and other people on the line, for social service people who are making those phone calls with families, do you think the Conversation Project would work over the phone with families to use that as a tailored intervention?
I think it would work. I also, in my clinical research and work, I think that informed surrogate decision makers, informed family representatives are more valuable than advanced directives. If you gave me a patient who signed a piece of paper at a 14 grade level and said, this is my medical wishes, versus a spouse or a partner or a loved one who says, I've known this person their entire life and I know that that's not what they would want. I would trust that person over that piece of paper because I know that that's what they want. And the Conversation Project does have, it's not necessarily what are your medical wishes, it's more who are you as a person and what would that person want in these medical situations. And I think that having these conversations at home with our loved ones is as important, if not more important, than having them with our providers. If we can make sure that everyone, if you told me no one would complete an advance directive, but everyone would have these detailed, lengthy conversations with their loved ones so that when they're sick and in the hospital, their loved one says, I know exactly what this person would want, I would take that over advance directives every single day.
Wow. Wow. So what I'm hearing is the social service people have these conversations and document the conversations
Yeah.
very well in the chart. Even if a legal document is not completed, at least that information's in the chart so the rest of the staff have access to it. But also if there's any issues month, 2 months down the line, it's documented.
Right. I should have put that qualifying statement of documented conversations are very important.
Oh, that's good. That's the nice thing about a small group. Between the 7 of us, we're going to get the main ideas out. I want to thank you so much for this, Ryan, and the Center for Practical Bioethics in making you available. And this has been such a huge service. I'm going to send the recording to you, Ryan, and see if it's okay with you for me to put it out on the listserv.
I can already say I would appreciate you sending it to me because I know our marketing and the rest of us would want it, but I have no problem with you sending this out.
All right. And thank you everybody for being part of this and for your questions and for your support. And we will continue as the National Nursing Home Social Work Network figuring out what we can do to support the frontline social service workers. Joan, do you have something that you want to say?
Question. I'm not sure if I'm on the listserv. I'm on the email, right? So can you send that to the email group as well? Thank you.
I will. All right. So I'm going to stop the recording.